Welcome to the X equals Primary Care Hackathon. I'm Kenneth Q.
And I'm Polly Ismoy. And over the next 48 hours, you will innovate, ideate, and create. Let's meet our advisory team.
Hi everyone, I'm Celia, Chief of Staff at XPC. I'm mostly behind the scenes. Super excited to see what everyone creates and the connections that people make during the hackathon. Good luck.
Hey everyone, I'm Stu Solomon. I'm an anesthesiologist and now the co-founder and chief medical officer at Orchestra Health. Throughout my career, I've built numerous health tech solutions, and I was really excited to be involved as an admin and mentor at this XPC hackathon. You can ask me questions about go-to-market strategy or implementation of health tech solutions in a clinical setting. I'm looking forward to seeing what you guys can build, and I'm here if you need anything. Best of luck.
Hello everyone, I am Gus Roman, and I will be your logistics sensei for the XPC hackathon. I'm most excited about you guys and your solutions that I know will be impeccably idealistic, exquisitely empathetic, and peacefully passionate. Looking forward to seeing what everyone here builds. Best of luck.
Hey all, I'm Dave Berner, coming to you live from Provence, France on my honeymoon. Cheers. I'm your AI, API integration, interoperability admin expert for the XPC hackathon focused on healthcare and AI. Super excited to see what you all built. We got a star-studded lineup of different organizations volunteering to allow you to connect their data. Really can't wait to see what you all build. Please reach out to me on Slack for any questions you have, and good luck, everyone.
Hi, XPC Hackathon. My name is Didi Einbinder, one of your co-hosts, and I'm so excited that you're here to join us. We have a fantastic lineup of sponsors, mentors, and fellow attendees just like yourselves, and I look forward to seeing what you build. If you have any questions about EMRs, integrations, or diagnostics, please come find me. I'd be glad to connect on Slack or on LinkedIn. Wishing you a great experience this weekend. Let's go improve patient care.
We've brought together some fantastic tools for you to build with and amazing mentors for you to engage with. As you build and brainstorm, don't hesitate to reach out to mentors, sponsors, and advisory team members.
This is your chance to build something amazing, and we're really excited to see what you build. To kick us off with some inspiration, here's our keynote speaker, Dr. Sarah Gebauer.
"15 years ago, I stared at a blank screen and realized how close all my patients come to death. I was in a hospital in rural Guatemala covering for the only anesthesiologist in the area so he could take a much-needed vacation. A young woman came in one night with appendicitis, and the local doctor was reaching his hand into her abdomen when the pulse oximeter stopped working. This happens everywhere. It's technology, it fails sometimes, we check the connections, get a new one if needed. Except in rural Guatemala, there is no new one. That was the only pulse oximeter, and it failed right in the middle of surgery. At that moment, I realized how dependent I was on the advances made by engineers, and by physicians and engineers working together. I spent so much time listening to the steady tones of the pulse ox beeping that when I was pregnant, I joked that the baby would recognize the sound of the pulse ox more than my husband's voice. I had met John Severinghaus, who ran the human studies to validate the pulse oximetry technology developed by a Japanese engineer named Taku Oyagi. I knew that the introduction of pulse oximetry coincided with a 90% reduction in anesthesia mortality. Since that moment, I see examples of collaboration between physicians and engineers everywhere in healthcare. As an example, let's look at the orders on an average primary care patient. We see a patient in his mid-50s with hypertension and new occasional chest pain. His family medicine doctor orders an EKG, a stress echocardiogram, and some lab work. The EKG uses technology developed by an engineer, Alexander Muirhead, in 1872, then refined and validated by physicians like William Einthofen, and for years has come with a rules-based interpretation that some would consider an early example of artificial intelligence in healthcare. The echocardiogram is a result of a surgeon named Inge Edler, who read about the radar technology and contacted a physicist named Carl Hertz. The lab work will include a troponin level, using radioimmunoassay technology developed by Solomon Burson, a doctor of internal medicine, and Rosalind Yalow, a nuclear physicist. Every test the family medicine doctor ordered relied on collaboration between a physician and scientist or engineer. The tools we rely on in modern healthcare that we take for granted and can't imagine practicing without have come from physicians, scientists, and engineers working at the intersection of healthcare and technology. The future of artificial intelligence will rely on today's physicians, scientists, and engineers working together to develop, test, and refine the products of the future. Artificial intelligence is still considered in its infancy, but has already made some exciting contributions to healthcare and primary care. The development of neural networks has already changed expectations for sophistication in medical technology. All the breakthroughs I just mentioned are already being refined and tested now with neural networks. Convolutional neural networks developed sophistication about 10 years ago and have allowed classification, segmentation, localization, and detection of abnormalities in medical images. Classification allows a chest X-ray to be labeled as pneumonia or atelectasis, for example. Segmentation can extract regions of interest in an image and help design custom implants for patients. Detection and localization find the objects of interest in an image like a stroke or an MRI. Convolutional neural networks assist with diagnosis of chronic eye diseases like glaucoma, cataracts, macular degeneration, and diabetic retinopathy. Much of this technology was developed at Verily, with physicians and engineers working closely together. Current technology allows them to function as cognitive aids to physicians, and may be especially useful to primary care physicians in areas of the world, like the one I volunteered at in Guatemala, where there are no radiologists. While some have predicted the demise of radiology, the limitations inherent in the current technology make it much more useful as an assistant than a replacement. Recurrent neural networks have been used for prediction of chronic disease, major medical events like heart attacks, and can help primary care physicians decrease risk factors. In the future, deep learning and recurrent neural networks will be used to personalize healthcare by identifying possible conditions far earlier, suggesting precision methods to modify risk factors, and optimizing dosing and medications. Deep learning will also customize care plans for patients at risk. Remote monitoring will keep people out of the hospital by identifying exacerbations of illness when they can still be treated at home. Widely available generative transformers were very quickly adopted by many physicians to automate some of the most boring tasks, like writing letters for pre-authorization. Many companies are trying to capture the market for decreasing administrative burden using generative AI. This is especially important since 66% of primary care physicians report burnout symptoms, and nearly half say decreasing their administrative burden would be the best way to relieve their burnout. Other administrative tasks in healthcare, like fraud detection and regulatory compliance, could be handled by largely AI in the future also. Across innovative institutions, some physicians already have access to software that listens in on their appointments with patients, writes the notes, orders the tests and medications through the EMR. The software acts as a cognitive aid, prompting the physician to consider a less common diagnosis or order preventative testing. When I started as a medical student, rounds at the hospital was just a bunch of doctors walking around from patient to patient. Over the last 20 years, rounds came to include nurses, then computers, then all the team members caring for the patients. In the future, AI will become part of that medical team as well. Just as the medical team has grown to include many perspectives, innovation teams have expanded. 100 years ago, new devices could be developed by a single physician picking up on a great idea of an engineer. Innovation of the future will depend on a group of talented team members with complementary skill sets. Of course, the integration of AI innovation will not be completely smooth. Innovation moves more slowly in healthcare than in other fields because one malfunction, as I saw in Guatemala, has a potential to kill a person. Collaboration amongst clinicians, scientists, and engineers to develop protocols that mitigate risk to patients is crucial. Major issues include bias, trustworthiness, liability, and explainability. Systemic bias has been demonstrated throughout the AI ecosystem, including healthcare. Data bias is especially prevalent in healthcare due to limited access to training data compared to the amount of data found in many of the foundation models. Addressing both of these biases will be a difficult issue that involves social and technical advances. You and your colleagues will be some of the leaders in the crucial role of identifying and reducing AI bias in the future. AI also produces lies very confidently, and these hallucinations can be deadly in healthcare. We've already seen examples of chatbots giving dangerous mental health advice. Along with the inherent variability in probabilistic AI models, hallucinations pose a major challenge. It's easy to lose public trust and very hard to regain it. Issues of medical liability also have yet to be resolved. When the AI makes a mistake, who's at fault? Concerns about liability may result in slow changes to practice patterns. Finally, we have to be able to explain how this technology works to patients, to clinicians, and explain to clinicians how to explain it to patients. All of you participating in this event are part of the future of artificial intelligence in healthcare. Making connections with people outside your fields and breaking through silos leads to collaboration and innovation. If you feel like you know just enough about another field to be dangerous, that's perfect. It means you know enough to ask questions and work with experts in that field to come up with a great solution. I watched the color of my patients' lips every moment that night in Guatemala, knowing that if they turned purple, it was the equivalent of an oxygen saturation in the low 80s. I remember the silence, the lack of the comforting sound of the pulse oximeter that I had come to rely on. I was lucky. She was young and healthy, woke up happy, feeling great without an inflamed appendix. Each one of you has the potential to create connections, develop collaborations, and build on existing technology to save lives, improve the lives of clinicians, and keep patients healthier longer. Thank you for being part of this event and improving healthcare.